Hey, I'm here with Dr. Michael Gardner. He's a orthopedic surgeon, and today we're going to talk about scoliosis treatment and some cool options that he has available online and some other things. I also want to pick his brain on his thoughts and ideas on scoliosis treatment. I met, well, this is actually the first time I'm actually meeting Dr. Gardner, and they reached out to me to see if we could collaborate on something, and I think it's a fantastic idea. So, Dr. Gardner, welcome, and kind of tell us about yourself.
Awesome. Thank you, David. Thanks for having me on. Great to meet you and really a pleasure to be here. So yeah, as you mentioned, I'm an orthopedic surgeon, work currently at Stanford University. And, my interest in scoliosis has really been spanning over a few decades now. When I was a resident, training in orthopedic surgery in New York City, started in 2001. And the way residency training goes, you get kind of finite blocks of the different subspecialties. And when I was doing my spine training kind of section was my first exposure to scoliosis. And, orthopedic surgery training is mainly around surgery. And so we had doing a lot of surgeries, and spine surgery is, as a new doctor at the time, it's shockingly major. It's a huge deal.
Yeah.
Yeah, I remember looking across the table at the main surgeon mentor of mine, being like, "Wow, this is actually like spine surgery to people. This is like unbelievably invasive and everything else." And
Yeah.
it was the modern principles, which is how it is. And then so it's a bunch of surgeries, but then you do go to you shadow your mentors in an outpatient clinic and talk to people, hear their stories, and it really after seeing a bunch of these surgeries, which just seemed like you would want to avoid this at all costs, and talking to people like how did you end up here? What was your path? And there were a lot of different paths for people with scoliosis that ended up getting this extremely invasive thing, but just started hearing a recurrent theme of like, I was a teenager and they missed it. And I was a teenager and they saw it, but the scoliosis specialist was 100 miles away and I didn't have pain and my mom worked and we just kind of blew it off. And then 10 years later, now it's worse and I'm in, and over and over and over about, and then there's some adult patients with scoliosis who have pain. And, I guess we can expand on all these system things later, but I just started seeing a number of different ways, like the medical system. And again, like, you go into surgery training, kind of very optimistic view and rosy view of the world, and just seeing how the system really is problematic for so many patients and how prevalent scoliosis is in adults. And so there's just problems with people getting effective treatments for scoliosis that don't involve surgery. And then also, almost all these patients were on pretty long-standing pain medication, and this was kind of even before, again, early 2000s. Like, there was mainstream media about the opioid epidemic, but
Right.
even then, it was like, I take two Percocets 3 times a day, and all the problems that go along with that. People hated being on pain medication, but that's what treatment was until you got to the point of needing surgery. So just these total disasters of system pathways and really sad patient stories. And then so went on. I actually kind of found a mentor that resonated with me, and he was an orthopedic trauma surgeon. And so as I was kind of deciding what to specialize in for my career, I gravitated towards that. But all along the way, I've always kind of kept an eye on and talking to my scoliosis partners and about how current treatments were going, how they change. There are technologies that are tried both for diagnostics and for surgical, kind of just following along with the field. And, we've all seen how technology has changed in the last 10 to 20 years. It's
Yeah.
come a long way. And, so then I had my first job in St. Louis, Washington University. And then I moved to Stanford about 7 years ago and got to know the scoliosis people here at Stanford. And Yeah, you just look back and like, wow, now we're in 2020 or whatever, and things are exactly the same. Like nothing has actually, at least in a 20,000 foot view, there are still the same problems with diagnosis, with access to good non-operative care, primary care physician, treatment of back pain. There's so many problems along the way, and so piqued my interest, and then also can get into it later, but decided to kind of find a technology and start an intervention plan and try to change the system really a little bit. Also, maybe a little idealistic, but really, and then now we've assembled a really passionate team, and we're really trying to change the system for so many people.
Yeah, and I think it's interesting you talked about how technology has really progressed so far, but really spinal fusion for scoliosis is, like you said, very similar to what it was a while ago.
Yeah.
And and how we treat, that's one of my frustrations as a physical therapist. How we treat doesn't necessarily reflect what's in the research or what's best for our patients at this point.
Yeah, 100%. Now, of course, spinal fusion can help some people. On this topic,
Yeah.
I, it struck me as so interesting again when I was first learning about scoliosis and surgical treatments. And many patients would come back, especially at an academic center, which is kind of a tertiary referral center. You get referred a lot of complex patients. And so many patients come in with this diagnosis that's called failed back syndrome.
Yeah.
And I'm like, what's that? How's this work? And it turns out like patients who have just had fusions followed by multiple other surgeries, chronic pain, and there's no real explanation or no true like anatomical or physiologic diagnosis. It gets put into this wastebasket bucket of just failed back. I mean, it says it all, right? Your whole team of doctors has run out of ideas and it's just failed. And we don't really know now what's wrong with you. And it's a terrible situation that so many people are in.
Yeah, I mean, you probably see it every day. I see it every day. It's all over the place. And there's got to be a better way to do that.
Yeah.
So what you kind of talked about what brought you to have a desire to work with spinal deformity patients. So kind of give us a rundown of how you feel like it can be improved. You gave us a kind of an overview of how it might be going wrong, but how could we improve that?
Yeah, for sure. So I'll give you the real high level view of
Yeah.
my thoughts, which are maybe unrealistic and kind of holy grail. But you know, unfortunately, the U.S. healthcare system is set up with some perverse incentives for physicians and especially surgeons. Being one myself, and everybody's practice setup can be very different. But in general, despite having indicators over the last 10 years that there's going to be some value based kind of medical systems coming into place, the reality is still, after having talked about that for a decade, the vast majority of medical care is fee for service. And so what that means as a surgeon is the more surgery you do, the more money you make. And it's
Yeah.
just human nature. These are bad people. I mean, me included. No, we don't have nefarious motives, but it's just human nature that when you're deciding on what to do for a patient, it's in the back of your mind. So anyway, what that means is that the scoliosis experts in this system are the surgeons generally,
Yeah.
and surgeons then are not incentivized to find and implement, be knowledgeable about, spend the time with patients to provide, effective non-operative treatment. You're just not incentivized to do that. And so that's one issue. Now, again, to change that in the system, I think a lot of people recognize that would be very helpful for a lot of reasons. That's obviously a major, a major thing.
Yeah.
Uh, and I guess on a smaller scale, primary care doctors, or the first stop for many people who have back pain, um, also maybe just a systems issue, but are tasked with screening, monitoring for dozens of diagnoses including back pain. But
Yeah.
you also may have a blood pressure issue and you need a colonoscopy and you've got anxiety. There's a million things that that group of physicians is responsible for taking care of. And so they don't have the time or training often or desire often to really dive into and spend time on patients back pain. So really there's this intake person, generally primary care, and then there's a specialist. And so in the middle, there's not a great system or service for patients to get education. I mean, the many patients that we see now, one of their main things is like, I just don't know what to do. Like nobody really tell me what my
Right.
options are. Should I see a therapist? Should I do this Schross? Should I do an injection? I just don't know. And so, education geared towards patients, I think could be much improved in the system. So I think that's a reasonable goal in terms of trying to improve things.
Yeah, and I think it's interesting because what you're talking about right now is what we deal with every day in physical therapy. I mean, I don't know how many patients come in that I talk to them and I'm like, "Well, what have you done?" And they say, "Oh, I've done an MRI, I've done injections, I've done uh, medications, I've met with a surgeon." I'm like, Has anyone tried to get you stronger or work with you conservatively?" And it's still surprises me. Of course, I'm a little biased to what I do, obviously, but it still surprises me how often we're not addressing the basics of it. We're trying to go higher level than I think we need to. And sometimes it's because some providers feel like patients won't do it or they won't be compliant with it. So why waste our time on it or something? I don't know. There's a lot of reasons, but yeah, there's a gap between that, in my
Yep.
opinion.
Yeah, I couldn't agree more. Uh,
So yeah. Um, so I think, you talked about having that, using those systems to get people better. What do you do in the practice that you're building right now? Like what do you change with that?
yeah, so we've tried to address some of the issues I've mentioned, and the first is access. So,
Hmm.
we've loved to see the Schroth therapy data become more and more and pretty clear that it works very well. Um, Interestingly, like even at Stanford, a metropolitan area in Palo Alto, patients looking to get Schroth therapy for their scoliosis have a hard time getting in, and they have a
Hmm.
hard time getting insurance to cover it. It's just they're the appropriately trained practitioners are sadly few and far between.
Yeah.
So anyway, access is one thing. So we are trying to so we've designed what we call the scoliosis solution. And what that is a starts with a 3D scanning app that's now FDA cleared that patients can take a scan of their back, both standing up and bending forward.
Hmm.
And the important thing, I mean, as you know, that scoliosis is not only a curve of the spine that we measure in two planes on an X-ray, but it's also a twisting of the spine. And so the more severe it is, the larger the hump or asymmetry of the back. And so it's amenable to be quantified by a kind of a surface scan. So we use kind of an AI algorithm to assess and measure the severity of the scoliosis. And scoliosis is very different aside from the magnitude of the location on the back, whether it's thoracic or lumbar or elsewhere. Anyway, so patients get a 3D scan, which can help provide our team some insights into the particular details of that patient's curve. And then we've got a virtual program of scoliosis specific exercises, kind of based on Pilates and there's some kind of some Schroth principles in here
Mhm.
that patients can get some guidance on a specific program from our team based on their scan and some other components of their history. And then they can go through some of our programs virtually. Now, obviously, downside of virtual therapy programs means you don't have somebody there helping you and coaching you, and that's obviously a
Right.
major component of physical therapy. Um, but we found that there are some exercises geared towards scoliosis that can actually be very effective. And we've got a ton of patients who have been helped by this. So anyway, so then it's kind of self-directed, on-demand, virtual exercise sessions. And then the third component is, I guess another symptom of patients not really falling into the purview of a specific medical um, practitioner type who has the time to spend is there are a lot of other ancillary services that people need and benefit from, like bracing services,
Hmm.
psychological services, in-person physical therapy, surgeons, support communities, et cetera. So we kind of help coordinate all of those things for patients depending on what their need is.
That's great. I mean, I think access is one of the hardest things for like really good scoliosis treatment now. I think Schroth therapy when I started so I got certified in 2015, and I was the only one in Utah at the time that was certified in Schroth. And
Wow.
now that's progressed, and I think most larger areas, metropolitan areas, have Schroth treatment available, but still access with insurance, access with I mean, I still have patients that drive 4 or 5 hours to come see me, and so
Wow.
it's it's
Interesting.
it's pretty common, but I think that's the smaller piece of the population who's willing to do that. And so I think having something where, like you're right, full-blown Schroth, I don't know that it can be done virtually or online, but I do think some of those principles like you're talking about can help guide people in the right direction so that I mean, something's better than nothing, right?
Yeah.
And that's great.
Yeah, and just on that topic, we've run a bunch of webinars just with some information about our program, et cetera. We get a lot of a lot of questions. Maybe the most common question we get is like, I've looked into Schroth, I'm signed up. Like, how does your program relate to Schroth? And what we've been saying, which is what we believe, is that Schroth is great, very effective, hard to access for most people, and our exercise programs are a great complement to a Schroth program.
Right.
And so it can be something additionally people can do in 15 minutes every day,
Yeah.
in addition to a formal session.
Well, and I like the idea of, and I was looking at your website. I think you have memberships that people sign up for, and I think that model, because one of the biggest struggles with Schroth therapy is compliance, and having a membership model can definitely help with the compliance aspect of treatment, whether that's in conjunction with Schroth, whether that's independent. I mean, whatever. If we can get people to do more, all the better, right? That would be amazing.
Yeah, exactly. Yeah, and we're working on some features of the app to kind of, ping for reminders. Here's your exercise today, and just kind
That'd
of
be
get
great.
engagement, because I agree it can help people when they do it consistently, but obviously, if
Yeah.
not, you don't get the benefit. But
Yeah, that's great. With the going back to the 3D scan, is that just done with their cell phone?
cell phone, you don't need any other hardware. You do need an iOS device.
Oh,
Uh,
okay.
yeah, so not Android yet, but that'll be coming soon. Yeah,
Yeah.
and you need someone else to take it for you. We have a bent forward, kind of bending forward with your legs straight, arms kind of touching heading towards the ground of the back, and then standing upright. So you need someone else to take it. It takes about 15 seconds per scan, and then they get sent right to us and our team for analysis.
So does that estimate the Cobb angle, or does that give any like specific objective data on rotation or ATR or anything like that?
Yeah, so it does estimate the Cobb angle. Um, Actually, we found that we've kind of got two different ways the device is used. One is for adolescents, where adolescent idiopathic scoliosis, kind of the priorities 1, 2, 3, 4, 5, or what's the measurement of the Cobb angle. So it does
Yeah.
measure that. We found in our adult patients, quantification of the Cobb angle is a little little less relevant for their treatment. And so
Agreed.
we're looking at some other metrics of, some pelvic tilt and shoulder asymmetry and skin fold, regions and things like that. But yeah.
Yeah, I think that's great. Yeah, whether the curve progresses 5 degrees in adult isn't as crucial as how their sciatica is because of that, stuff. Yeah.
Exactly right. Yep.
So, well, that's cool. I've used surface topography, so kind of a 3D scan since 2016, and that's pretty cool that AI is helping to really crunch the data that we can get just from our cell phone. That's just amazing.
It's interesting. I know you guys use the deer scanner.
Yeah.
Yeah. So the deer scanner was actually kind of our inspiration a little bit.
Oh yeah.
Uh, our advisory board members were kind of early researchers and publishing the deer scanner kind of
Mhm.
research. And so it first kind of indicated the necessity for a non radiation based quantification of the deformity,
Yeah.
but also kind of getting back to the technology issue we were talking about. Like, yeah, this deer scanner is super cool how surface topography works. But now in 2023, with AI and cloud storage and camera resolution, can we capture what the deers does on a cell phone? And it turns
Yeah.
out we can. So that's what we use is surface topography
Yeah.
using a depth sensor camera similar to a deer scanner.
Yeah, it's pretty amazing. And I feel like after having surface topography in my clinic, I mean, I've been using it now for almost 8 years. Um, it the feedback that my patients get immediately with that, and that we don't have to worry about X-ray and we don't have to worry about anything like that. And we can do that and compare those side by side. And sure, they may not agree completely with an X-ray Cobb angle or something like that. But if we're comparing the objective data that's giving us, that's huge. That helps with compliance. They don't wonder where they are. They can see that their exercises are effective and things like that. So I think it's fantastic.
Yeah, so that's interesting. So you mainly use the deer's data for kind of patient demonstration and discussion, and like here's our progress or
Yeah.
in that nature.
Yeah,
That's
so I'm
really
not using it for diagnosis.
yeah.
Most of my patients have an X-ray anyway, so that's the diagnosis aspect of it. We try and correlate it with what the 4-metric is showing, but really I'm looking at a 4-metric scan to show pelvic imbalance. I'm looking at to show rotation. I'm looking at sagittal plane, and I mean all kinds of things. And it's easier for them to see than an X-ray where you're like, yeah, you see the pedicles are rotated, and they're like, I don't know what you're talking about.
Yeah.
You know?
Yeah, the deer scanner is really cool. And I guess I will say I'll walk it back a little bit. Like our technology is based on similar. The
Right.
deers has a bunch of cool metrics of rotation and a bunch of parameters and measures that we don't fully measure quite yet, but we're planning to get there.
Yeah, but I mean, heck, it's gotten this far in just a couple of years, probably. Imagine
Yeah,
what we'll be able to do in 5 to 10 years.
yeah, totally.
So, yeah, that's pretty cool. So what what suggestions would you have for those with scoliosis? Like, say someone's listening to this. You treat mostly adults, it sounds like.
Yeah.
And so if you had someone come into your clinic, what are some suggestions, advice, anything like that you'd give them?
Yeah, totally. So I think the first thing is just based on what we've heard from so many people when we first get in contact with them is like, so, you know, if you have pain from your scoliosis, and many have heard like, if you've got back pain, it's not from your scoliosis because that's painless from their doctor. If
Right.
you, if you've got pain with scoliosis, if you feel like the system has kind of like ignored you,
Mhm.
um, you know, it's important to realize you're not alone. There's tens of millions of people. Uh, and, by the time many people come to see us, they've tried a lot, like, you're talking about too. Like, I've had injections, I'm on pain medication, I've tried standard therapy.
Right.
So many have tried a lot of things. So I guess the next thing I would say is like, don't give up hope. There are things to try before surgery, and most patients have heard that surgery is a last ditch effort, which I would concur with. You avoid that at all costs. But there's hope. There are other ways to eliminate your pain um, without surgery and without medication. And so, yeah, those would be some major messages, I guess.
Yeah, the big thing that I see with my adult patients is they've kind of been told, like I had one yesterday, he's like, I'm on my not on my last, I'm on my sixth or seventh injection, and he keeps hitting bone and he can't get to the right spot, and those aren't helping, and I've tried medication, but I'm kind of done with that. I'm not ready for surgery, or maybe they're progressed too far that surgeons won't touch them, and they're kind of left to I don't know,
Right.
figure it out on their own.
That's right.
And so
Yeah.
those patients that are not, they're not ready to throw in the towel as I mean they shouldn't be, but they feel like they need to because everyone said, just deal with it and wait until it gets bad enough to need like major surgery or something. Sounds like those people are kind of perfect for the program that you have.
I think so. It's something else to try. We've had great success. We're partnered with kind of the one of the largest scoliosis specific exercise schools in the country, and we've got great success. So yeah, I think it's worth trying. It's something you can do proactively every day on your own and get guidance from our experts, et cetera.
Yeah, I mean, even if we can get people just to sit a little taller and fight gravity a little bit more, I mean, heck, that would be success.
It goes a long way.
Yeah,
I
so
totally
cool.
agree.
So a quick question on the prevalence of adult scoliosis. I was talking about this with some of my therapists yesterday, and and I don't know that you have an answer to this, but we always talk about adolescent scoliosis as like 3% of the population, give or take. Um, I've seen some research that shows adult scoliosis or spinal deformity is quite a bit more than that. Some studies all the way up to like 24% or something like that. Um, I don't know if you have any data or any insight into that. How prevalent is this condition?
I do actually. So there's two really interesting papers. One found that in patients over 60, the
Hmm.
prevalence was 68% of patients over 60 with a Cobb angle greater than 15.
Wow.
And, now not all of them are symptomatic,
Right.
but about half were symptomatic. Another study was a meta-analysis of kind of epidemiological studies of 4,000 patients,
Hmm.
38% of those patients over 40. So we ran some quick
Wow.
numbers, and there's about 192 million adults in the United States. That means about 65 million adults in the United States have scoliosis. And again, about 32 million have symptoms at one time or another, mainly pain from their scoliosis. And it often continues to get progressively worse, which is it's too bad that the adolescent idiopathic story is often that scoliosis is pain free. And then once you hit skeletal maturity, it doesn't progress. And we're just knowing that
Not
that's
true.
just not the case. Yeah.
Yeah. And those are big numbers. I mean, those are significant.
Yeah.
And it surprises me all the time when I see one of my chronic back pain patients or a back pain patient. Like my mother, for example, she came in one day with trochanteric bursitis, and I was assessing her, and I'm like, we have a pelvic imbalance here, and I look up, she has scoliosis, and from being in a boot from a foot fracture, and
Yeah.
those things can happen to pretty much anybody. It doesn't have to be that you are diagnosed as an adolescent to
Totally.
have that happen. So
Exactly.
yeah, there's a lot of people out there that this can help because a lot of them are told, yeah, your scoliosis isn't causing your back pain.
That's right. Yeah, exactly.
Right.
Yeah, and I just quickly say on the incidence thing, and what you just reminded me is, so yeah, they're kind of we think of scoliosis in adults as being in two types, right? Some are adolescent that progress, but others, termed adult de novo scoliosis, develop as adults, and this is more of a degenerative nature, but it's scoliosis and it's a structural source of back pain, nonetheless. So
Yeah, and it needs to be treated from 3 dimensions. It doesn't need to be, well, core strengthening is helpful and important, yes, but we need to take into account the curve and the imbalances that are there. So I think
Exactly.
that's great. So if someone is interested in pursuing, getting in contact with you or figuring out how your stuff might be able to help them, what do they do?
Yeah, thanks, David. So we have, I mentioned the scoliosis solution is a part of the National Scoliosis Clinic.
Mhm.
And so the information about our program is on nationalscoliosisclinic.com. Again, it's a monthly membership with cancel anytime, money back guarantee. So, if things aren't seeming like they're a good fit for you, cancel anytime. And so we've had very few. Interestingly, we launched about 4 months ago, and we've had very less than 10%, less than 6% of people who end up canceling. So the vast majority of our patients are finding value and getting pain relief and continuing with the program. So we're super excited to keep building and growing and helping as many people as we can.
Yeah, I mean, that's fantastic. There are people who may not be as compliant with full-blown Schroth treatment coming to see me that may totally benefit from this. Or this
Yeah.
might be a good addition to help people be more consistent with the stuff that we work with them on. So I think there's a lot of opportunities for that. And good for you
Absolutely.
guys for putting it out there. That's fantastic.
Thank you. Yeah, we're excited. The team is all pretty fired up, and we're moving. Things are moving quickly, and we're
Yeah,
seeing a lot of just really great testimonials, which we post on our internal messaging. Like, this is kind of what drives us to keep going. People just like, I am at my end of my rope, and thank God I found you, kind of thing. And so it's really what drives us.
that's great. What's coming in the future for the National Scoliosis Clinic? Is there something else in the hopper?
Yeah, absolutely. So we've kind of prided ourselves as being a very customer centric company. So we talk to our customers every day, and we
Mhm.
get really interesting feedback. Like any offering, what we think people want isn't necessarily so we're listening to people, and we're getting a lot of great ideas for building our product roadmap. So there will be a number of interactive features, obviously much more programming. We're doing some exercise series on like osteoporosis and scoliosis,
Hmm,
foot issues with scoliosis, pelvic floor and scoliosis. So there's a lot of sciatica and scoliosis. So
fantastic.
some specific programming and some interactive things, and some automation as the AI continues to improve as well.
Yeah, much needed and easy access for people. That's what I think is going to be really really good for it. So
Yeah.
I'm actually curious to go in and sign up and scan somebody and see how that works. That sounds really cool.
Yeah. If you're interested in using it as a practitioner, we
Yeah,
definitely talk. That'd be really cool.
that's great.
Yeah.
Any last words of advice for those listening?
No, I guess the only thing would be, again, don't give up hope. Back pain is tough. It changes your life. Treatments are available. It's a bit of a marathon, and so there are no magic bullets, unfortunately. But with a little bit of persistence and focus on exercises you learn with David or do separately on your own, work on every day, your lifestyle can be improved and your pain can be decreased.
Awesome, awesome message. I appreciate you being on the podcast with me, Dr. Gardner.
Yeah, thanks so much. Appreciate it.